So, hello, my name is Stephen Dean. I am COO and co founder of Keona Health. And today we are talking about workflows. Now, I'm joined today by Gina Tabone, MSN, who has over 25 years of experience inside of contact centers and advancing telehealth. During her time with Cleveland Clinic as the administrator of Nurse on Call, she participated in the development of work from home programs, nationalized contact center, a program called Access to Care, and moved on to consulting for other contact centers. And so she knows ins and outs of healthcare, contact center experience, and workflows. And I'm very excited to have the conversation. Welcome, Gina.
Thank you, Stephen. It's great to be talking to you today. I look forward to really diving into workflows and their value in not only the telephone triage process, but just patient access in general. So it's truly a vast topic. So I'll be relying on you to keep me on track and redirect it as I go on and on about different experiences, successes, failures, while trying to manage process flow and what has now come to be known as workflows.
Good. So let's start at the beginning, a little bit about your background and how you came to this. What was your introduction to workflows inside the call center?
And we're going to go way back here, Stephen, probably to about 1999 when I first started my career in nurse triage. At that time, I was working with Cleveland Clinic for a department called Nurse on Call. And Nurse on Call at that time was a public offering to residents of Cuyahoga County, northeastern Ohio, primarily the underserved, the uninsured. And it was Cleveland Clinic's response to having to satisfy their nonprofit status on their tax return. So there had to be some
Mm,
sort of offering to citizens who did not have access to health care. So
mm,
out of that need came this department, Nurse on Call. It was simply a 8 to 11 Monday through Friday service for the underserved in Cleveland. Just dial a number, very easy to remember, 4441234, and call, talk to a nurse, and she'll tell you what to do. At that time, the workflow was really simple because we were simply talking to patients who really weren't our patients. We were talking to local residents who reached out to us. And I mentioned that they were not our patients because we really had no true obligation other than we were nurses caring for patients. And true obligation, I mean, we did not have to page a doctor for intervention. We did not have to call in prescriptions for these people. We didn't know who their doctors were. And keep in mind, too, Stephen, going back that far, there were no electronic medical records. So what we were doing was very cut and dry. All workflows, when I first started, essentially revolved around how to navigate the software.
mhm,
Hours and hours were spent trying to train the nurses, myself included, how to operate the computer, just clicking through. It was very elementary. That's a workflow. And we're going back, Stephen, to the cow printed boxes of gateway days, the gateway computers. It was a lot of how to operate these manual phones, put them on hold, conference, get to the operator. So it was a lot of workflows around how to operate the equipment. I will say, probably, we did at that time have guidelines, and I don't even know, Stephen, if they were called software at that time. They were somehow in this computer device. You typed in a symptom and the guideline came up a lot like it is today. And so we did have that. And probably when I was thinking back about workflow, The primary workflow that we had to introduce us to the job was the initial responsibility of classifying the call. Was it a physician referral call? Was someone just calling for health information? Or did someone truly have a symptom based call? And of course, the ultimate, whatever won out, whatever any reason was a person was calling for, was a symptom based call. So when we talk about workflow, I think of that because symptom based calls were handled differently than health information or physician referral calls. Back to the very beginning, we did have a workflow that was embedded in our telephony. Like the newer nurses would have skills based routing. Like, for example, when public callers would come in, the IVR perhaps would ask them, are you calling about a patient over 18 or a patient under 18? Because sometimes there was more anxiety with new nurses handling pediatric calls versus adult calls. So the skill based routing allowed the nurse to receive calls that were a result of the caller selecting adult. So even in that sort of a primitive way, it was the start of the workflow for symptom-based calls. That's kind of where we were in 1999. And in 1999, when we said again, there's no electronic medical records, we were covering for public patients. That's how we started out. But providers within the organization of Cleveland Clinic, especially the primary care doctor, internal medicine, began to realize, wow, this is a great service. How can we utilize this for ourselves? And that was when we came in and became part of the Cleveland Clinic's continuum of care. So the nurse in the office would take care of the patients during the day. And then at 5 o'clock, when the office is closed, phone lines would roll over to their department, and then we would start covering for their patients after hours. And always going back to the very beginning, it's sort of what we do today is the goal in the very beginning was to mimic whatever was done in person in the offices or in the clinic. So if we just sort of think about it today, you go to the doctor's office, you check in, okay, you're here for your appointment, confirm your date of birth, confirm your address, then you sit down with somebody else, they confirm your insurance or they verify it. Sometimes we need to have a pre-authorization for a procedure. So we had to be sure as we began to take care of established patients that we were performing the same sort of administrative tasks in addition to triage that were being done in the office. So in the very beginning, a lot of focus was on, we have to do everything that's being done in the office here. We had different tools to work with, but we were able to make sure that we were talking to the right person for the right reason, and we were the right person to resolve their issue at that time.
So you started with a service that sounds like that was more cut and dry and was as simple as healthcare triage can be, probably. But then you ended up growing, working with providers, and really having to address all sorts of calls, topics, administrative issues, and the complexity sounds like really skyrocketed.
It did. At first, we had no idea what this service would snowball into. So we have these very cut and dry encounters with public patients. Here's
Yeah.
your symptom, here's the questions, here's the disposition, do this. You weren't going to do it, you needed a prescription, go to the ED, that was it. Again, Cleveland Clinic began to realize this is a vital service we should offer to our patients. So at that time, Cleveland Clinic was nowhere near what it is today. So we started out with this one main campus, and we started out with the internal medicine practice there. So maybe at that time they had 15 internal medicine doctors. So we're going to cover for you after hours, okay? We cover and we start meeting, the phone lines roll to us. Hi, I'm returning a call from the office. Okay, the office is closed. You'll have to call back in the morning. Can you leave them a message? What do we do with those patients? Hi, I called the office today. They were supposed to call in a prescription for my refills. They didn't call it in. Okay, what are we going to do for those patients? So as we took on this initial practice, we started to discover all of the different situations that could possibly arise for
Mhm.
which people were calling us about after hours. Not only what was expected of us, what patients expected of us, but probably at that time, the hardest audience to satisfy were the physicians. Just the unique expectations that
Mhm.
physicians had of our service. And keep in mind, in the very early days, again, there was no electronic medical record. So we started out faxing every encounter to every doctor's office as they occurred, just so that they had an understanding of this is what occurred with your patient. We told them to do this, or they went to the ED. While it was a continuum of care, communication was very poor at that point. While it was crazy, we still did it. We at that time had no, I used to say we were like the Rodney Dangerfield of nursing. We really got no respect because
Mhm.
nobody really knew what we were doing. So in the early phases, hey, your every wish is our command.
Mhm.
We did not have any skin in the game to make demands or decline the offer. So we start out with this big internal medicine practice at main campus. Fast forward a few years, Cleveland Clinic is beginning to grow all over the map. So wherever there was primary care, nurse on call became an after hours offering.
Mhm.
So again, we start out with main campus, these 15 doctors, then we had another 15 doctors from the
Mhm.
west side. And we have this doctor here who, when he joined Cleveland Clinic, he had a partnership or he helped his good friend who was the sheriff of Medina County. So this doctor on the west side of Cleveland who practiced for Cleveland Clinic, because he joined Cleveland Clinic, we honor all of his requests. So not only are we covering for him, but when he's helping out his good friend, the sheriff, his line rolls to us at Nurse on Call. So now
Mhm.
we're talking to the Ohio Highway Patrol whenever someone dies in a car crash on an Ohio highway. Again, that was
Yeah.
just that one go live, one doctor.
Mhm. Yeah.
So grow, 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 add on more buildings, more practices, do more acquisitions. And before you know it, the job and the minutia that the nurses were expected to be able to not so much know, but locate,
Mhm.
identify, and honor all of these requests, the job became so complicated.
Let's jump forward just a little bit because you've really set the stage for growing complexity and a snowballing practice. I want to give people kind of a hint for why they would spend a lot of time focusing and perfecting their workflows. Could you tell me what a great workflow that has been honed over years and years do for you?
I always speak to topics from the nursing perspective, okay? A great workflow for nurses is, and especially, it's never been more relevant as it is in this day and age. It's really being able to utilize our nurses at the top of their licensure so that we are really employing them and allowing them to provide clinical care.
Mhm.
Okay. So in the early days, nurse triage, where I worked in a lot of call centers, it was a nurse first model. Nurses were answering the telephone and they were confirming who the patient was and, getting a little bit of demographics. This was really the early days of HIPAA. HIPAA really has done a lot to influence all of healthcare's workflows. You can't be talking to the wrong patient. You can't be giving information about a
Mhm.
patient to someone else unless it's authorized. And really and truly, a lot of our so-called referred to as upfronting process, the clerical or administrative work done early on in the call is probably a result of HIPAA. We just used to say, okay, who am I talking to? But now, I mean, some organizations have two, three patient identifiers, but having that not be a role or an expectation of a nurse has really become the norm in nurse triage.
Mhm.
It was viewed as too expensive to have nurses doing administrative tasks. And we touched on this before, verifying demographics, even gathering insurance information or confirming it. So we wanted the nurses to really be able to just, as soon as they start their conversation with the patient, they are honing in on, what is going on right now? What symptom are you having? Is there anything going on possibly right now that this patient may need 911? So I think that from a nursing perspective, removing the barriers to just allowing nurses to be a nurse has made the greatest impact on triage. And a lot of this was sort of done behind the scenes, or not behind the scenes, but just it's been absorbed primarily through technology. The best workflow improvement has evolved around nurses being able to just function as nurses. And it really eliminated a lot of distractions. Nurses that have workflows that just guide them down the path without the interruptions of having to stop. Let me put you on hold for 1 second while I look into that. Being able to give nurses the tools, not only clinical, but the non clinical tools that they need performed for them to best do the job for the patient.
Yeah, a lot of what you're talking about is simplifying things for the nurse too, and limiting the number of things that they have to focus on so they can focus on a lot of their clinical tasks, the focus at the top of their licensure. But, even in order to do that, you have to have workflows that are robust enough that non-clinical are handling a lot of the tasks that when you're at Cleveland Clinic, the nurses were having. What we've seen with really honed workflows is that it allows people with lower health education to be able to handle more calls. You don't necessarily have to rely on a nurse. It helps lower your training time because they know exactly where to go to look for how to handle each call, right? You get a higher quality. And so instead of, some people answering the call, handling the call great, and others just like, oh man, I feel sorry for every patient they talk to. You have better standards across the nurses and the agents. And then the providers, you said the providers are hard to satisfy. But if you can capture their requests and requirements, I mean, even if you take that work off of the back of the nurses, someone's going to have to do that, right? The non-clinical is going to have to be satisfying, or you just tell them, we have certain standards of what you're going to do or able to do when you're on call, and playing for the symphony can't be one of those. You got to switch your on-call days. But other than that, a workflow has to handle it, right? So you have consistency across staff, higher provider satisfaction, lower training time, and you can then have higher user satisfaction. You already mentioned this, the nurses operating at the top of their licensure and being happier with the work that they're doing, you know, instead of feeling frazzled and running all over the place.
And you said the word standard just a moment ago. Centralization happened. What at least we began to realize, and as a consultant, I realized in a lot of organizations too, a lot of people were doing a lot of their work on the telephone. These people, a lot of times, were occupying space, desks, offices, that as
Mhm,
organizations began to grow, they needed that space more and more. So
mhm,
we saw an effort to, or not really an effort, a mission to get all of these people together in one space, this economy of scale. It was actually being done
mhm,
much better in other parts of the world than it was in the United States. We at one point reached out to a call center in Ireland to better understand how they were doing non-clinical issues. They were
mhm,
covering for cell phone companies or car companies. So we began to learn from them about sort of call center centralization 101. And we really then began to understand that we really wanted things to be standardized, uniform, consistent, reliable. And reliability I always think goes back to research. We want the same outcome when this particular process is followed, no matter who is following it.
Mhm.
So, we took that to be nurse triage initially. Use these guidelines and use your critical thinking skills, follow our processes, and if done correctly, the same patient with the same symptom talking to different nurses at different times should be given the same disposition. So,
Mhm.
the standardization and the effort towards that and the recognition that the big bang theory kaboom business hit healthcare, and it not only mattered that we gave patients a cushy warm feeling and they were so happy to talk to us, but money was coming into the forefront, and payments and efficiencies, and eliminating waste. I mean, eliminating waste was a big driver of a lot of actions that were taken in healthcare. And
Mhm.
call centers and remote care, it's no different. So we began to recognize the value of standardization from different countries and industries. Healthcare began to take on successful traits and practices from a lot of different industries. And for the most part, it was helpful. There were times it wasn't. Talking to people about your cell phone bill and talking to a nurse about, your horrible back pain, it's not apples and apples. But still, there were
Mhm.
great efforts to extract and incorporate what would have worked and what would not have worked. But we were trying to go from an era of hold the pickle, hold the lettuce, where everything was an exception, to a pretty much uniform practice. There were some exceptions that were very necessary within different practices, but there were also times where we were creating workflows that were simply based on the idiosyncrasy of a physician.
Mhm.
Okay.
Mhm.
And
Right.
maybe idiosyncrasy is a little sarcastic. I don't mean it to be, but
Mhm.
we had to accommodate it because we wanted them to understand that we were here to help you. And we are not here to say you don't know a darn thing about how we have to talk to your patients. So some of the exceptions that we made to some of these workflows, we simply did as a goodwill gesture to the doctors. It was interesting. I want to go back and say one thing, Stephen. I did it with the Cleveland Clinic when we centralized department after department after
Right.
department. It
Yeah.
was a year build. It was 6 months activity with a scheduling team, a triage team. We were centralizing all services. So if there were 15 different sites at Cleveland Clinic, where there were 15 different locations where internal medicine practiced, our access to care, our centralized service, brought all of these groups together. And we were trying, it was like herding cats, trying to get them all together to come up with standard workflows for
Mhm.
this particular specialty. And one thing that is so important is a discovery phase. By that, I mean, after I left Cleveland Clinic, and I certainly learned it from their consulting, I worked with 30 different organizations while I was at Cleveland Clinic, all around nurse triage. A good portion of my time was spent initially side by side, listening in and monitoring and tracking the types of calls that were coming in on that line. It was
Mhm.
the only way that we could get an understanding of what we had to prepare for, what we needed a workflow for. Come July and August, there is an increased demand in getting permission slips for sports physicals signed in pediatric practices. So, understanding what patients were calling about was essential to creating specific workflows for different
Mhm.
practices. Workflows for OBGYN are very different than workflows for pediatric practices. So,
Exactly.
understanding and doing a great discovery process is essential to mapping out workflows that really address the reasons that your patients are calling for.
Absolutely. So, and there's a lot of work there, and that can scare people a bit, but they have to realize what they're overcoming. So let's just back up just a little bit, right? Before you figured out this whole process of standardization, when your nurses first started taking on the primary care facilities and they didn't have documented workflows, what was that like?
And it goes back really to the very early days of nurse on call. At the time, triage nurses really, we were not considered a specialty of nursing. And nobody knew what we were doing, really. We were in a basement in an old, dilapidated building.
Yep.
Nobody knew what we were doing. It was a very traditional way of teaching nursing. You had a one on one preceptor. We talked about this in great length in our video about the history of nurse triage, but
Mhm.
it was a labor intensive process, one on one, 6 months orientation. So you would be one on one with a nurse, either listening in on her calls, she was listening in on your calls. You sat next to someone for 8 hours a day for 6 months. So what was done was you picked up habits from this particular nurse that you sat with, and
Mhm.
you took on her demeanor a lot. But then she was on vacation or she went on maternity leave, and she would always page a doctor when the patient refused to go to the emergency department. Well, she goes on vacation, and then you're sitting with Betty. There began to be, not began to be, there clearly was, everyone you with gave you their opinion, their
Mhm.
process, till you went and on your own, whatever stuck with you, you did. And then you started precepting in a year down the road, and you tell the nurse how you do things. There was an awful lot of that, but that's how it was in bedside nursing too. I could remember my first job out of nursing school was in the ER, and there you got so much practice inserting IVs.
Mhm.
Every nurse that you were with had a different secret, a different way of doing it. So at that time, tradition was the way that nurses were trained from one nurse to another. And then we began to really see the evolution and advancement of evidence based triage. And it was through the AAACN, American Ambulatory Association for Nurses, that began to really pursue and research telephone triage, because it did essentially fall under the umbrella of ambulatory nursing. We weren't hospital nurses, med surg nurses, OR nurses. So
Mhm.
they really did a lot of the hard work in coming up with the expectations and the clinical background for really turning triage nursing into a specialty.
So you would go from a situation where the training was really because it wasn't documented, people are doing their own thing. It's a mixture of people doing their own thing, but then sometimes doing the right thing, but they have to pick it up because it's tribal knowledge. And so they pick it up by shadowing and they pick it up by hanging around people who are doing it and just absorbing it over time. By creating the workflows, you help move it towards standardization, but you also can pick up the speed at which people learn things because they can see it written out. They don't have to wait and watch and shadow over 6 months in order to figure out how to handle all the different workflows that they may end up taking. Took that process of starting to standardize and work out the workflows and then applied that. This is where I was talking about your own innovation at Cleveland Clinic to the discovery and what types of calls are we getting and how are we going to handle those as you start taking on the call support for primary care practices.
It became impossible to identify every type of scenario that would pop up. Just for example, like just thinking back and talking to some of my peers that I worked with in the early days, just last night, we were talking about like some of the workflows that we had to create. And Stephen, you know what? We're saying workflows. And last night it was really interesting because we referred to everything to workaround. Everything was an exception. So we had this straight process. We had to come up with process flows or things, like we eventually went to only Cleveland Clinic patients.
Mm.
So then it was like, what's the workflow when a caller slips through? They're staying at their aunt's house, who's our patient, for Christmas break, and they're sick and they call. What do we do for a
Mhm.
non-established patient? We became the clearinghouse for any critical results after hours. How do we handle those? What's the workaround or the workflow for that? What do we do when someone calls us to tell us one of our patients has expired? How do we go about notifying the doctor of that? Newborn births. The nursery would call the doctor's office, but it was 3 a.m., so it rolled to nurse on call. What do we do with newborn notifications? Because back in those days, the pediatrician had to get there within so much time. So we began to really creating processes that we wanted our nurses to follow in all of these particular situations.
Building off of what you said, because again, I think a lot of people don't have a good sense, particularly people who have not worked inside the contact center. But even those who have don't have a good sense for the items that you're talking about and how complex. And it feels like every single call that comes in is an exception. And that's just because it's really a testimony to the complexity of the issues that you're dealing with. And it takes a lot of thought and work to build those into your processes. You've got patient complexity, right? They might have comorbidities, be in different places. They have their own preferences. You talked about earlier the provider complexities, right? They've got their own uniquenesses, and every single one of them has, different ways that they want their patients handled, and maybe different ways that they want that documented. You've got the different workflows. Every primary care facility you supported, I'm sure, had their own workflows, even for, or the own way they wanted things handled, even for the exact same type of call, because they hire different people. One might have a department for billing, one doesn't. I mean, who knows, right? I mean, it just goes on and on. One will split a type of visit into two different visits, the other doesn't, besides not having the EHR integration. So you can't even, you're flying blind in your case for not being able to see a lot of the data. And then thinking of the clinical escalations, how are you going to handle those? The list goes on and on and on for the number of complexities that you end up facing in healthcare.
We talk about, mapping out workflows or creating workflows. And fortunately for us, as time has evolved, technology has come a long way. And a lot of the workflows, our end users, they know how it works within the clicks within the technology we use. But fortunately for us, we no longer have to think about these things. It's already done for us automatically. It makes the job a lot easier. The outcome is phenomenal when workflows are properly mapped out. Being a consultant working with all of these organizations, that was the hardest thing to get organizations to allow to happen. It's got to be inclusive. If it involves a step through the telephone system, it's got to involve the telephone people. It's got to involve the EMR people. It's got to involve the schedulers who are supposed to get the call. So you really need all of the people in the room at the same time for this exercise. The best thing, or maybe not the best thing, but what it does, it identifies who should do what when, what their responsibility is, how we're going to measure it, and bottom line, how we're going to hold you accountable if this is not done. And
Yeah.
that was really, I think, something that people were afraid about. I did a huge nurse triage go live with an academic medical center in the Northeast in Maine. First of all of the people I met with, telephone, can I see your workflow for the schedulers? We don't have one. The schedulers. Can I see the workflow for this type of a call? I've never seen it. Can I see your orientation manual? I didn't get an orientation manual. So it's a very, very tough job. And we've talked about this a lot in different presentations that we've had. But this is yet another example when an organization makes the commitment to centralize, standardize, create nurse triage. The people, the end users are not the ones that are signing the contract to do it or with the consultant. They're not the ones signing the check to pay the consultant to be there. It's someone at a very high level. As you go from practice to practice, or you start this workflow mapping process, centralization, everybody on board, you need that central leader to always be looming in the background so that it's communicated that we've made this decision, but just give us a chance.
Mhm.
And you really need that central person or your leader to be visible. You need to be able to call on him in situations of resistance. And resistance, 9 times out of 10, is a physician. So most of the
Mhm.
organizations that I did deal with, the CEO was a physician. So this was a doctor to doctor issue. So you really need that to keep things moving along because it can get a little ugly. But I'm talking about this particular situation in Maine where there were no workflows anywhere to be found.
Mhm.
So patients would call internal medicine, they'd be on hold for 45 minutes, they'd never get through to a nurse. They'd get through to an operator. Every Monday, there were 700 patient encounters that had not been handled from the previous week. Something was drastically wrong with that workflow. And
Mhm.
that's just a crazy example. Even the nurse workflows, we had nurses that were so dismissive of the patients. There was no way to monitor them, there were not recording calls. So we really had no idea what the nurses were doing. So some were so dismissive and really kept the patients at risk by not treating them appropriately, caring for them. But then there were other ones who were so involved, so deep and enmeshed in the patient dilemma that a call took them an hour and 15 minutes. There was a need across the board to create workflows, communicate them, teach them, enforce them, and hold people accountable. I think that that's a big part of people do have some trepidation about is that they are going to be held accountable for things once they're put on paper or embedded or sort of just declared.
So there's the trepidation, but the flip side is you end up having, that backlog of hundreds of calls, and you end up having a hard time onboarding people. I don't know that we've really dived into the staffing, but the stress for staffing when they don't know exactly what's expected of them, right? And
Mhm.
they're winging everything and probably just getting criticized for this, that, or the other for calls they don't hardly remember that happened 3 weeks back. If you were to finish this statement, what would you say? A good workflow is like what?
To me, it's like GPS. All
Mm,
I have to do is put in, get me to Terminal Tower. I don't even have to think in the car. That is kind of where we see our workflows capable of being
yeah.
today. Not
Mhm.
everybody has the tools to be able to do that. And Stephen, where we came from, what we were talking about earlier, like in 1999, what were workflows like? If today workflows are GPS, back
Mhm.
then it was like an atlas. Highlight your route for yourself, don't share it, or go to AAA, get max,
Mhm.
open them up. And those were the old days. Today, GPS, it's on our phone, it's in our car, it is there. I have nieces and nephews in their 20s. They've been to my house hundreds of times. They still GPS it to get to my house.
Mhm.
They don't know a
Mhm.
street name. Give them a detour. Oh, forget it. They'll go back home. A lot of the call center stuff is equatable to traffic and traveling. And we want smooth sailing down the road. Once in a while, oh, there's an accident or a tree falls and we have to detour. So we
Mhm.
want to be prepared for it. It's a lot like navigating traffic, and the smoother the sailing, the better we plan for it, the more we understand and know where we're going, the easier the job. So I do think of it in some way as, workflows are our GPS.
Fantastic. Thank you so much, Gina. So, folks, we will be having some
Thank
other
you.
sessions on workflows. We've really just barely scratched the surface here. And if you need your nurse triage, your patient experience, your patient access to improve, the number one and probably the number 10 thing to work on are going to be your processes and your workflows. Thank you so much, Gina, and we'll be talking to you next time.